Welcome to RUMC Connections. Welcome to RUMC Connections. My name is Meredith Gaskins, and I'm joined today by Dr. Sean Galligan, the Associate Director of Cardiology at RUMC. Through RUMC Connections, you'll meet the doctors, nurses, and medical professionals that make our hospital thrive. We'll provide useful information about your own health, explore the latest medical news, and hopefully get you answers to your own health-related questions. When you or a loved one are suffering from a cardiac condition, you want to know that you can trust your physicians. That's why Richmond University Medical Center employs highly skilled, board-certified, knowledgeable cardiology specialists. They provide every aspect of patient care, from prevention to treatment to monitoring, and with a personalized touch to address each patient's unique needs and concerns. Non-invasive tests for cardiac conditions provide physicians with valuable information about some of the risks that typically accompany more invasive cardiac procedures. RUMC offers a full range of non-invasive diagnostic cardiology test procedures, which we will discuss some of today. So Dr. Sean Galligan is a highly qualified and competent cardiologist who serves his Staten Island community with experience and expert care. He began his medical education at St. George's School of Medicine. After graduating, he completed his postgraduate training and fellowship at the SUNY Downstate Medical Center. Dr. Galligan's focus in school became the specialties in which he would later become board certified. These include internal medicine, cardiovascular disease, and interventional cardiology. Dr. Galligan is registered in vascular interpretation and a member of several prestigious national organizations. His memberships include the Society for Cardiovascular Angiography and Interventions, the American College of Cardiology, and the American College of Physicians. So, according to data from the CDC, it reveals that heart disease is historically the leading cause of death in the United States, claiming nearly 700,000 American lives annually. Tell us about coronary artery disease and how people can use screenings to help diagnose it.
Yes, thank you. Thank you, Meredith, for the wonderful introduction. Certainly cardiovascular disease or coronary artery disease is consistently the number one threat that people take for morbidity and mortality. That's why everything is aggressively evaluated and risk factors are reduced and whatnot. Regular screenings start with just a regular EKG, trending up to a stress test, echoes, echocardiograms, and then go further into any sort of intervention or further diagnostic testing that we need.
Absolutely. Okay. So what would you say are some of the most common symptoms that someone might be experiencing coronary artery disease?
Well, there's a wide range. Most common, the classic, chest pain, chest tightness, radiating to certain areas such as your neck or your arm. Sometimes associated with some shortness of breath or nausea. But these are the typical symptoms. But there's a lot of people, sometimes the majority of people, they present with some, all, or none of those symptoms. And it's really, sometimes can be very difficult to tell. That's why we do a heavy evaluation and we have these tests. And we know that typically patients that have other comorbidities like diabetes, sometimes they don't present with these symptoms, or even women themselves, they don't typically present with the typical symptoms.
Yeah, and women's symptoms are different than men's typically, right, that they exhibit for
heart
disease?
They tend to have a higher tolerance for pain, and they do have the non-typical symptoms. So we do have to take certain risk factors into account and have a high suspicion. That's why we use the testing, blood tests, and just our history and physical to evaluate them.
Mm-hmm. So now, is there a certain age that people should consider getting these evaluations done if they're not exhibiting symptoms?
The long-standing development of cardiovascular disease starts to exhibit symptoms probably in the 5th and 6th decades, so 50s and 60s. We do see that with patients that are higher risk due to family risk factors, genetic risk factors, they can present much earlier. So see patients in their 20s sometimes, just evaluating risk factors, making sure that, going forward that they can take the lifestyle changes or, reductions so that you reduce those risks of it occurring. So every patient's different, but typically you start, screening roughly around the 50s and 60s, sometimes even earlier.
Great. And can people make a direct appointment at the cardiology clinic, in RUMC, or do they need to go through their primary care physician to get a referral first?
Yeah, they can make a direct appointment with us. Typically we do see patients referred from primary care because that's usually where patients start, just with their annual physicals.
Yeah.
We see them, they can come see us directly as well.
Okay, great. So tell us about some of the benefits of cardiovascular stress tests and how they can help diagnose coronary artery disease.
There are a number of different types of stress tests, just regular treadmill exercise stress tests up until, we do stress nuclears where we use nuclear imaging to look closer. We also have the stress echocardiograms, and these tests are used for screening purposes, specifically the exercise stress test, which is, getting to the point where sometimes it might be a little bit outdated, but it is good for younger patients that we have a low suspicion that they have a certain disease, and we want to see their exercise capacity, what they can do on the treadmill, and look for any EKG changes during that. Typically, the other testing with imaging is usually a little bit more sensitive and more accurate as far as determining if there is any sort of coronary artery disease present. Along with stress testing, we're also using more and more frequently over the past year or two is CAT scans, so coronary CTs, calcium scoring. These are all used for risk stratification as far as their cardiovascular disease and for diagnostic purposes as well.
So are those kind of phasing out the stress test and becoming more popular, would you say?
Certainly calcium scoring is becoming more and more popular just because it's quick, it's easy, it's relatively inexpensive, and you get a good gauge as far as someone's 5 to 10 year risk of having a significant event, so you're able to prevent that.
Okay, so it gives a prediction into the future of what could happen to the patient.
Yeah, exactly. Patients are exposed to a relatively low dose of radiation. They don't need contrast and other stuff, so they're good. And coronary CTs are essentially, being used to as like a non-invasive angiogram per se. So you're actually able to see the anatomy. Just like with anything, every patient's different. The characteristics are different. Risk factors are different. So we try to gauge it on what the information we want to do as far as to evaluate them.
Got it. Okay, that makes sense. So let's talk a little bit about echocardiograms. So who would be a candidate for an echocardiogram?
Basically anybody. Typically we'll get an echocardiogram to evaluate the structure and the function of the heart. Use it to evaluate murmurs, to look at valvular disease, whether they have stenosis or regurgitation, which is essentially if the valves are getting tight or if they're becoming leaky and they're not working the way they should. We use that. It's a quick, easy test. Low risk, doesn't expose patients to anything, and we get a lot of information from it. Not only just the function, but also hemodynamics and other stuff we're able to derive from it.
And that test is via ultrasound?
Yep. Just like ultrasound, just like routine stuff, get ultrasounds for anything, babies.
Yeah.
That's a typical one.
Oh, no, of course. Can you tell me the 5 abnormalities that you can detect with an echocardiogram?
Oh, 5. Oh, there's a lot of abnormalities. But 5 basically most common ones. You look for dysfunction in the heart muscle, how it's functioning, whether it's not squeezing appropriately, whether it's too stiff. We could look for valvular stenosis. We could look for valvular regurgitation. We look at size and measurement of the heart and the chambers. So there's a lot. To limit to just 5 is a little tough, but it's the amount of information we get from such a simple test is very, very useful. That's why it's so widely used.
Okay, so when you're looking for something that might be an issue, you would see some swelling, or what would you see in the ultrasound that would alert you of a problem?
Yeah, just for functional purposes, the heart, you may see the heart muscles not contracting appropriately, whether it's it's not contracting strong enough. I mean, we typically use a measurement called the ejection fraction to evaluate the overall strength of the heart. Typical range from anywhere from like 55 to 65, 75, really depending upon the patient's age and function. Anything lower than that is a little concerning for a decrease in function, and then what it's caused for. We also look for measurements of the thickness of the walls for hypertrophy, whether it's due to longstanding hypertension or other genetic issues.
Okay, that makes sense. Yeah. And then what will patients experience during an echocardiogram? It's
a relatively easy test to undergo. I mean, typically we have our echocardiographic technicians that do it. They'll come in. They are hooked up to electrical leads just to monitor the electrical activity in the heart, and then they use essentially a small probe, use ultrasound gel. So it's a little cold jelly on the chest, sometimes warm, depending upon if the warmers are working, and just take pictures. Sometimes they may feel a little pressure just from pushing on it so we can get the right images, but overall it's a very easy test to
relatively quick too, right?
Yeah, 15, 20 minutes at the most.
And that gets you views of all angles of the heart, right?
Yep, it gives us all views from the left ventricle, right ventricle, all the valves.
Did you say before that there's more than one type of echocardiogram?
Yeah, well, I mean, as far as the usefulness of echo, so there's a regular resting echocardiogram where patients are just laying on a stretcher and they're getting the test done. There's stress echocardiogram where we incorporate an exercise stress test into the procedure, or sometimes we use medication to increase the heart rate and the contractility of the heart. And that's more to evaluate either to look for ischemia in the heart or a blockage in a coronary artery. Also to look at valves and how they function. Just as with the coronary blood flow, which supplies blood to the heart, that changes with exercise, so does valve function. So that is sometimes used to evaluate. And typically, when valves get stiff, we also use it for when they become leaky as well. And then there's also transesophageal echocardiogram, which is a little bit more invasive. We typically require sedation. And that's essentially done with a probe that goes down the throat, just like you would like an endoscopy or EGD. And with that, we're able to look at certain areas of the heart that we're not able to see as clear on the regular transthoracic echo to look at the valves, because there's less tissue in the way.
Yeah. Okay. So you get a different view.
Yeah.
So those are the most popular types, you would say?
No, most popular is transthoracic. That's the most common. We use a transesophageal for when we're looking for certain specific issues, whether it's stuff that's stuck to the valve or if there's clot in the heart in certain areas where we can't necessarily see super clearly on the transthoracic imaging.
Okay. That makes sense. So with the CDC report of, this increase every year, it goes up pretty significantly. Are you seeing a trend here on Staten Island of any kind of cardiovascular issues, a certain age you're seeing more of, or anything along those lines?
Yeah, I mean, we do see pretty steady flow of pretty much all age groups. Looking back, I mean, we haven't calculated the data, but I mean, hypothetically, or just by observing it, we may have seen a little bit more trend to younger population. Mainly, probably because I think in the past, within the past 3-4 years, especially with the pandemic and everything, a lot of people have not. They've been weary on going to the doctor, and now they're coming back, so we're picking up some things, but for the most part, it's still pretty much the bread and butter is 50, 60 and up is what we deal with.
Yeah, and I'm sure the sedentary lifestyle that a lot of people had throughout the pandemic hasn't helped things either.
Yeah. I mean, just in general, the U.S. tend to shift towards a sedentary lifestyle, so that is it's a risk factor. It brings up high blood pressure, high cholesterol, development of diabetes, and those are all significant risk factors, as well as smoking. But certainly as well with the pandemic, that everybody was not everybody, but there was a large amount of people that were not going out, not exercising like they were before, whether it's because their gyms were closed or they just, they were a little apprehensive about going out in public, and they weren't as active, and that certainly contributed to it, I believe.
Absolutely. And I'm sure, like you said, certain other comorbidities kind of go hand in hand with cardiovascular disease. We've had Dr. Otterbeck on as a guest, and he was saying, especially since the pandemic too, and the sedentary lifestyle that, has, been an ongoing problem here, that there's been such an increase in, diabetic patients getting younger and younger. And I'm sure, you see that impact on the cardiovascular health as well.
Yeah, no, absolutely. We definitely see more and more diabetics, especially with, just due to diet, inactivity and being sedentary, that certainly can contribute to it. Typically, type 2 diabetes. Mm-hmm. It is a very, very significant risk factor for cardiovascular disease, and something that we work hand in hand with endocrinologists as well, to make sure that their A1Cs are controlled and sugars are controlled, so that it prevents the progression of anything from occurring.
Yeah, of course. Okay, and so can you tell a little bit about what an EKG is compared to an echocardiogram and what you see on that test?
Sure, absolutely. So electrocardiogram is probably the most common cardiovascular test that's done. I mean, it's done in primary care offices. We do it on every patient that comes in. If you happen to end up in the emergency room, you're going to get an EKG. And we, as cardiologists, treat it as kind of like a vital sign. And what it's actually showing us is the electrical conduction and electrical activity in the heart. Based upon what we see on there, if there's abnormalities in certain waves and intervals and whatnot, we can have an idea of what's going on. We do use it in acute situations as well for someone that's having an acute heart attack, to determine whether or not they need urgent intervention and procedures. But a lot of times it's suggestive of certain things, and then that kind of directs us down the path of further testing as far as stress testing and echo.
Okay, so those would kind of be your next go-to steps after the EKG if it shows any abnormalities?
Yeah, absolutely.
Okay.
Absolutely.
And how about an angioplasty? What types of patients is this procedure performed on? Okay,
so angioplasty, or what we call percutaneous coronary intervention, the technical term. That's kind of the end stage as far as working up coronary artery disease. So after someone comes in and is evaluated, they'll get the EKG, then we will send them for echo, stress testing, depending upon if there's abnormalities, symptoms, and if those symptoms aren't controlled with medications. A lot of times they'll end up in the cath lab, and essentially an angiography is we're looking directly at the coronary blood flow. We use little kind of tiny little catheters that go up there, and we inject contrast, and we take a look. If we see blockages, we're also able to do certain hemodynamic testing during the procedures, and if something is deemed significant and are causing symptoms or causing damage to the heart, we're able to basically reperfuse those vessels with angioplasty and stent placement. We use little balloons. We just open it up, and then in goes a stent that keeps the vessel open. Also, not as simple as that too, because a lot of these patients with multiple risk factors, sometimes they end up being candidates for bypass surgery. So that's another option. So it's when we talk about the overall invasive treatment of coronary artery disease, we talk about revascularization, and that's with either PCI or surgery. Mm-hmm.
So does an angioplasty require a stay in the hospital, or is it a quick outpatient procedure?
Well, certainly there's patients that are, they're already in the hospital.
Okay.
That's I'd say I don't want to say majority, but a good amount of the patients that get stents are ones that come in for acute issues, for acute heart attacks and whatnot. But for on the outpatient basis, when we do it, previously it involved staying over in the hospital, whether one day, sometimes two, depending upon what needed to be done. But nowadays we're doing it, they come in and they go home the same day. And I think that's a good thing, especially for the patients. We're also doing it more, I'd say probably 90% of the time through the wrist, which helps with the patients are able to ambulate. They don't have to lay as flat. Yeah. It's typically before it involved going through an artery in the leg. Okay. We still do femoral axis or leg axis, but
It's through the wrist now, isn't it?
Yeah, most of
Okay.
the time. Most of the time.
Yeah.
Yeah, it's you talk to the generation before me. The predominant axis was the leg, and then probably about 10 years ago or so, give or take, that's when there was a big shift towards radial axis.
Yeah. Are there any advances on the horizon for that procedure? You think it'll evolve to?
Well, every day, every year we're seeing more and more advances in interventions. It's advanced at a tremendous amount since it's been started. It was started to use in, I'd say, probably late 70s, early 80s was the initial time. It went from just balloons to then putting stents, and the stents that we use now, they're super thin. They got they're drug coated. They have certain polymers on them to prevent any adverse events happening from it. So that they're extremely good, and they're always re-engineering them and looking at ways to improve stuff. Not only just stents. We're looking. It's also being not so much in the U.S. now, but in Europe they're also using drug coated balloons. So not even putting stents.
Wow.
So that's something that could hopefully come within the next 2 to 3 years to the U.S. when we're able to use it on a regular basis.
Yeah. So would you say you're using an angioplasty as almost a preventative method to try to avoid the bypass if possible?
Not so much avoiding bypass. We use angioplasty or stent placement for acute events, someone with acute heart attack that comes in. It's basically the first line intervention for that.
Okay.
And anyone that has angina or chest pain from coronary artery disease that is not responsive to medication, whether stenting or surgery, those are both options for that. And then again, depending upon the patient, whether if they're a good candidate for surgery, typically because longer term outcomes in certain patients have been better with surgery. Frailer patients or patients that don't want to undergo surgery, or if it really depends upon their risk factors and whatnot.
What are some of the most common medications that you might try to use to control these issues?
Yeah, absolutely. I think the one that everybody knows is aspirin, just a regular baby aspirin. That blocks platelets and helps prevent them from forming clots or thrombosis in the arteries. We also have a number of other antiplatelet medications, clopidogrel, ticagrelor. Those are all used for when patients get stents or if they're having an acute event. Hyperlipid medications such as statins. That's another one that everybody knows, and there's a lot of people that are apprehensive about taking them. But the statins have been shown recently to be very, very good at reducing the risk for acute events, and that's really what we want to do. We want to prevent someone from having a heart attack and potentially putting their life at risk. Yeah. So they've been shown to reduce the chance of that up to about 30%. Wow, so it's they're very good medications.
And what advice are you giving to your patients to take steps on their own that they can do to improve their cardiovascular health?
There's a lot. It's typically diet, exercise. Diet there's a lot of different diets out there. Everything from keto to intermittent fasting. There has been some evidence that shows that some of them may help, but typically the diet that we usually recommend is the DASH diet. It's essentially it's kind of like what we call a Mediterranean style diet. Less red meats, more fish, fresh fruits and vegetables. Low saturated fats. You don't want less butter, more kind of olive oil sort of idea. Typically that's what it is. But a lot of the times, I try to tell all my patients, it's more moderation. You're gonna have a burger, you're gonna have a steak. But you don't want to have that every day. You don't want to have that all the time.
Yeah. Everything in moderation.
Exactly. Moderation, I try to tell them, is the key, because realistically, someone will follow the diet for a period of time, and then they're going to be like, "Oh, I'm done with this," and move on to go back to what they were doing before. I think it's a little bit more realistic for them to just moderate stuff. Also, exercise. Exercise is a big key. It doesn't have to be a lot. You don't have to be running marathons every other week, like, my partner, Dr. Rotatori.
Dr. Rotatori, yes.
Yeah, but but it is important to stay active. I try to tell my patients walk. Try to do, 20, 30 minutes a day just to maintain. And it doesn't all have to be at the same time. If it's just a matter of parking a little further away and walking into the store, or even if they want to walk around the mall for 20, 30 minutes, do that stuff, or a little longer. But it is good to have a little bit more of a intense exercise or walk faster.
Yes, of course. So I'd like to use our last few minutes together to get a little personal.
Sure.
Maybe you could tell people, I know it's a stressful profession to be in. Is there anything that you like to do to decompress?
Yeah. I mean, there's a lot of stuff. I mean, we have a young child at home, so she's 16 months.
Oh,
so yeah, that most of my time now is spent, going home and playing with her and trying to teach her things and trying to get her to say "daddy" first. It's tough. But, no, she's doing that. Spending time with my wife, family, of course. And just staying active, trying to, I like cooking, play hockey. I haven't played in a little while, but I do play ice hockey. I've been playing since I was about 8 years old. So,
wow.
Yeah. So
it's a fun sport.
Yeah, it is great. It's fun. Just got to avoid the injuries. That's all.
Of course. And for our final question, do you have any patients that may stand out to you, a story that resonates, most memorable experience that you had?
Oh, that's a very good question.
You had a lot.
Yeah. Probably my most memorable, right off the top of my head, is I'd say probably the first patient that I stented that was having a heart attack when I came out of fellowship.
Yeah.
I'm not going to give her name, but I still see her to this day.
Wow.
She's doing great. I think it's it really
it's a beautiful thing to know that you saved someone. Of course.
Yeah, just to see them progress and do well is really, really really fulfilling, and makes it all worthwhile. The hard work and the time we spent for training and going through residency fellowship. It's a long road.
I'm sure. Absolutely. So. Well, I'd like to thank you for all that you do to keep us safe and healthy, and for joining us today.
Oh, you're certainly welcome. My pleasure.
Yeah. That about does it for this episode of RUMC Connections. For more information about cardiovascular services at Richmond University Medical Center, or to schedule a consultation, people can call 718-818-7425 or visit www.rumcsi.org. Thanks for joining us. I'm Meredith Gaskins.